Hello, I'm Ruth Bergen from WHRIN, and I'd like to introduce the latest global data on gender-responsive harm reduction programming around the world. First of all, I'll just describe quickly why we decided to undertake this mapping exercise. We determined that it's really important to document and promote harm reduction services that are operating with a programmatic gender lens in design. For example, by employing women and gender diverse peers, by including women-only spaces and times, comprehensive sexual and reproductive health services, including gender-based violence services, gender-responsive information, education and communication tools, provision of hormone replacement therapy commodities through needle and syringe programs, and so on. Many organizations providing these services lack opportunity to document and promote their important work simply because they're operating on a shoestring and flat out just doing that service provision. But we felt that it would be very helpful to enable and accelerate replication of these important services by mapping them where they exist per country and per region, so that that data can be used by advocates to point to living examples, so that in turn funders and public health planning can be confident in supporting these essential public health approaches within and between countries. I'll describe a little bit about the method that we used. We started this work in 2021 and engaged focal points drawn from the allyship of WHRIN, so that includes women and gender diverse people who use drugs with a knowledge of harm reduction services in their country or locale. Beyond that, we also cast the net wider to include harm reduction providers and others, and also augmented through literature review, just in acknowledgement that in some countries the environment is very oppressive against drug user organizing, and it was not always possible to reach a community member in each relevant country. Qualitative data was also drawn from WHRIN community consultations and is also referenced in the report. The document is importantly a living document and subject to constant update and review. So we are very keen to know about new projects as well as ones that are closing down, and to have links so that people can read more about the respective organizations and their work. So the findings of the most recent update of the mapping, in contrast to 2021, were that there was a very modest increase in the number of services in some regions, but the overall picture is largely static globally, with overall evidence of rarity falling very short of meeting the scale of demand and need. Canada was standing out as having a relatively high number of services that met our criteria, but also were falling short in reach and scale. Myanmar is another noteworthy case in running some pace-setting gender-responsive services for women who use drugs despite the extremely oppressive current country context, which demonstrates also that harm reduction services can improve gender inclusion through minimal budget adjustments, largely through smoothing referral pathways to allied services, along with making low or no cost internal adjustments, and even in the most oppressive of environments. However, depending on the needs voiced by communities of women and gender diverse people who use drugs, budget implications should, of course, be considered in planning and grant writing phases for harm reduction programs. I wanted to quickly reflect on the cover image used in this mapping report. It has a large eye representing the gender lens, and inside the eye is a woman under a tree with one piece of fruit high in the tree, out of her reach, indeed reflective of our overall mapping findings. This is not for want of evidence in terms of needs and, as a basic public health imperative, and in terms of gender equity, nor is it due to the lack of normative guidance or capacity building resources, some of which are linked in the mapping report. But in the current global climate, which is threatening the erosion of hard-won gains towards gender equality, it is more critical than ever that we work together to defend and expand evidence-based programming for the most marginalized of communities. Efforts must likewise continue towards decriminalization of drug use, including legislation punishing pregnancy and parenting among people who use drugs. Such efforts must now be redoubled in resistance to harmful conservative ideology. We must join together and stay true to course to uphold fundamental gender equality and human rights goals. Associated punitive systems or systems associated with prohibition and punitive practices must also be actively dismantled. For example, this would include addressing exclusion from domestic violence shelters for people who use drugs. In some countries where opioid agonist therapy is available in prisons, women's prisons are left out. And in several countries, OAT dosing is not yet linked to maternal facilities. We know that community-led harm reduction services provide optimal relevance, reach, impact, and value for money. This needs to be reflected in sustained funding allocations from governments and donors alike. LGBTQI people who use drugs must be meaningfully involved to ensure that harm reduction services are reflective of their needs. And lastly, we must work together to ensure that gender-responsive harm reduction services are sustained and replicated. Please see the link here or search for WHRIN Global Mapping to access the full report. Thank you.